Welcome to this webinar that is organized by a collaboration between EURO-NMD, the European Reference Networks for Neuromuscular Disorders, EURO-NMD, the European Reference Network for Rare Neurological Disorders, the EPICARE ERN for rare and complex epilepsies, and European Academy of Neurology. As you may know, this is the final of a series of webinars that were organized to mark the 2022 Awareness Week around mitochondrial diseases. We have had Chiara a fortnight ago speaking about movement disorders in this context of mitochondrial diseases, but she is also an expert in the optic nerve presentations of the mitochondrial diseases. And so we have again, for those who did not attend, I would remind you that she works in the Institute of Neurology, Neuroscience in Bologna, and she is about to become associate professor in waiting, and she's an expert in mitochondrial diseases, which are a field where she has vast publications and much interest and collaborations. And just to remind you of the housekeeping rules, you're able to chat between yourselves using the chat tool. You can also and should also use the Q&A tool to put your questions. They will be answered at the end, and if you're willing, you can voice them. And we are now starting our mitochondrial optic neuropathies by Professor Chiara Morgia. Chiara, welcome. Thank you very much for accepting our invitation again. We are very grateful, and the floor is yours.
Thank you for the nice presentation, and it's a pleasure for me to be here today. So, as you heard, I will talk today about mitochondrial optic neuropathies, and I decided to start with these are my disclosures. I decided to start with a clinical case, introducing the most common mitochondrial optic neuropathies, which is Leber's hereditary optic neuropathy. So you can see here we have a 16-year-old male, and he presented with bilateral acute visual loss without pain when he was 16 years old, so he's an adolescent. He had a family history positive for LHON, and the mutation was known as being 11778, which is the most common Leber's mutation. So as you can see from the fundus picture, initially the patient presented with this pseudoedema of the optic nerve fibers around the optic disc. And you can see this edema also by OCT, which is a very useful instrument to evaluate the optic nerve in this disease. And visual fields, I don't know if you can see my pointer, maybe not.
Yes, we can.
Okay, so here you see from the visual field, you have this central scotoma, which is typical for the initial stage of the disease. And you can see by OCT, besides the pseudoedema of the optic nerve fibers, also the presence of this initial ganglion cell defect, which is very typical for Leber's because the papillomacular bundle is very early affected by the disease. So when the disease progressed, you can see that this defect in the ganglion cell complex is increasing by size, and you also see this reduction of the edema around the optic disc, and it's clear that the papillomacular bundle is very early involved in the disease processing. And as the disease progresses, the visual acuity usually goes very low, and you can go like to counting finger. Even for the very severe cases, you can reach also light perception. Luckily enough, in this case, we were able to perform gene therapy. And as you can see in the final follow-ups for this patient, the final visual acuity was quite good for the left eye, for example. So to summarize, the typical picture of Leber's is typically affecting young males. You can have, but it's important to know that cases can be also sporadic, but in some of the cases, you can recognize the presence of a family history along the maternal line. And the clinical onset is typically acute and can be unilateral or bilateral. And there is no pain without movements. And this is very important for the differential diagnosis with, for example, optic neuritis and papillitis. There is no recovery of visual acuity with or without therapy. And the fundus image, you can recognize this typical macroangiopathy, telangiectasia, and pseudoedema around the optic disc, even though you have to remember that some cases may have a completely normal fundus images. Initially, visual fields show the central scotoma, as I showed before, and you can recognize this increase in the retinal nerve fiber layer thickness by OCT, but can be normal, don't forget. And if you perform fluorangiography, a difference with the papillitis, where you can recognize a leakage of fluorescein, in Leber's, typically you don't have this leakage. And for Leber's brain, MRI is usually negative for the myelinating lesion, even though occasionally the presence of hyperintensity of the optic nerve and the optic chiasm can be recognized also in Leber's patients. So this is the most common mitochondrial disease, mitochondrial optic neuropathy. And in terms of genetics, you have to know that this is due to mitochondrial DNA mutation, and the three most common are listed here. The most common is the 11778, which accounts for around 60% of cases. Overall, these three mutations account for 90% of Leber's cases. There is this male prevalence, which is around 5:1, the ratio between males and female, and you have this incomplete penetrance, which means that in the same family, all people along the maternal line are carrying the same mutation, but only some of them, and maybe only one of them in each family, will develop the disease. And the probability to develop the disease is much higher for males than females overall. As I said before, there is this acute onset in the majority of cases, and there is, these mutations are affecting complex one of the respiratory chain, you have this complex one defect. So an interesting issue about mitochondrial optic neuropathies, and specifically about Leber's, is that even though the mutation is ubiquitous, so you have the mutation in all tissues, you have this preferential involvement of the optic nerve. And the reason for this is mainly due to the organization of the retinal ganglion cells, which are characterized by this unmyelinated portion before the lamina cribrosa, with high mitochondria content and high energy requirements. And then after the lamina cribrosa, you have the myelinic component, which is different in terms of bioenergetic requirements. This skewed organization makes the retinal ganglion cells particularly vulnerable to mitochondrial dysfunction, which is at the basis of Leber's. In fact, as I said before, Leber's hereditary optic neuropathy is characterized by the preferential involvement of the papillomacular bundle, which is running from the optic disc to the macula, in which parvocellular retinal ganglion cells are more vulnerable to mitochondrial dysfunction. And the reason for this preferential involvement of the parvocellular component is mainly due to a not favorable ratio between the size and the volume of the cells. As I said before, these three mutations account for the majority of cases and are all affecting the complex one of the respiratory chain. The prevalence of disease is around 1 in 30,000 persons. But it's important to remember that besides this classical Leber's mutation, you can have also this rare mutation, which can be responsible of the same clinical expression of the disease. So if we want to highlight which is the typical natural history of the disease, you are moving from an asymptomatic stage when you have the mutation, but you are not manifesting any sign of the disease, even though if you do the fundus imaging of these carriers of the mutation and the OCT, you sometimes can recognize some subclinical changes like a mild microangiopathy or a pseudoedema of the retinal nerve fiber layer. When you move from the asymptomatic stage to the subacute stage, which is classified before between the onset and 6 months, you see this hyperemia of the optic disc. The edema is much increasing around the onset. And then you move from this subacute stage to the dynamic stage of the disease between 6 and 12 months from onset. And you can recognize this clear temporal pallor of the optic nerve, which becomes complete in the chronic stage. And you can see this diffuse optic nerve pallor. Something which is very important in terms also of early clinical diagnosis is the use of this clinical biomarker, which is provided by OCT imaging, in which you can recognize very early, before you see anything in terms of retinal nerve fiber layer, you can recognize this early ganglion cell loss, which can precede the onset of visual symptoms in some cases. So looking at the specific fundus characteristic of these cases, for Leber's carrier, as I said before, these are two brothers. You can see, for example, in this brother, there is a lot of pseudoedema. I mean, there is an increasing of the retinal nerve fiber layer thickness, even though the patient is completely asymptomatic in terms of visual acuity. And you can recognize sometimes also microangiopathy and abnormal color vision. In the acute stage of the disease, you can recognize this increase in the microangiopathic feature of the fundus images. This is a fluorangiography, by the way. And you have this acute onset of central visual loss. The patient can present unilaterally, but usually the second eye becomes affected in around 6-8 weeks, can be shorter, this interval, even though very rarely unilateral cases are reported. The visual loss is progressing in the first weeks and usually reaches the nadir in about 4-6 weeks, around 1 month after the onset. So as I said before, the combined use of fundus imaging and OCT can make very easy to follow the stages of the disease. For example, in this case, you can see, for example, this patient was affected in the first eye 3 months before, and you can clearly recognize this defect in the papillomacular bundle. This is the eye not yet affected. And if you look at the onset of the disease, you can recognize this increasing hyperemia in the left eye, and the right eye, which is the first affected, is already presented some temporal pallor. And the progression of the visual field defect from a central scotoma to a more generalized defect. In the chronic stage, which is usually reached about 4-6 weeks after the clinical onset, the optic nerve is completely pale and can be recognized in the advanced stage of the disease, also the presence of optic disc cupping, which is in differential diagnosis with the glaucoma, for example. Some recovery of visual function is possible. The probability of this spontaneous recovery is higher for the 14484 mutation. And in this case, the probability of spontaneous recovery is around 60–80% of cases, which is quite high, and is lower for 11778 and 3460 mutation, and is estimated around 15–20% of cases, even though a complete recovery of visual function is very, very unusual. The positive prognostic factors for visual recovery are age before 10 years of age, having a big optic disc size, and having the 14484 mutation. Another important clinical characteristic of Leber's patients is the maintenance of the pupil light reflex, even in the very late stage of the disease. So even though you have a complete optic nerve pallor and you have a severe optic atrophy, when you are running the pupil light reflex in this patient, you can still recognize the presence of a pupil response. The explanation for the maintenance of the pupil light reflex is related to the maintenance in this particular disease of these melanopsin retinal ganglion cells, which are a small group of retinal ganglion cells, around 1% of the total retinal ganglion cells, which we have shown to be particularly resistant to neurodegeneration in mitochondrial optic neuropathies. The reason for this resistance is not well understood, but the maintenance of these cells, which are mainly contributing to the photoentrainment of circadian rhythms, but they are also implicated in the regulation of the pupil light reflex, is the explanation for the maintenance of pupil reflex in Leber's. I want to highlight, however, that in the acute stage of the disease, when you have just unilateral presentation and you don't have yet the involvement of the second eye, the presence of a relative afferent pupil defect can be recognized. So, as I said before, the use of optical coherence tomography helped a lot in the understanding of the disease and in the understanding of the stages of the disease. This is an instrument that is now used also by neurologists and allows to measure the thickness of retinal nerve fiber layer around the optic disc. And in Leber's, you have this temporal increase of the retinal nerve fiber layer, which is involving first the temporal and inferior sectors of the optic nerve, which are the first undergoing thinning in the disease course. So there is a clear temporal course of thickening, which is involving first temporal and inferior, and the last sector which underwent thickening is the nasal sector of the optic nerve. So to summarize about Leber's, when we have to suspect Leber's hereditary optic neuropathy, when the patient is presenting a bilateral acute subacute visual loss without pain, especially in young males, even though the peak of the disease is estimated being around 15 and 30 years of age, but there are also childhood cases, and we observed also cases after 6 years of age. I have to underline that the later cases usually are people exposed to toxic, for example, smoking, and the typical age of onset of the genetic cases is around 15 and 30 years of age. As I said before, usually brain MRI is negative for the myelinating lesions. You don't have leakage at floor angiography. You have this evidence of microangiopathy, optic disc hyperemia, and pseudoedema. And there is a mild or absent relative afferent pupil defect. There is no recovery spontaneously and after steroid therapy, especially in the initial phase of the disease, and can be present a family history for visual loss along the maternal line. So the three most common mutations are the ones that we have to look for first. But if the clinical suspicion is very high, we have to run the complete mtDNA sequencing, looking for rare mtDNA mutation, which are accounting for around 5–10% of cases. Rarely, Leber's mutation can be associated also to plus phenotypes, which means that you don't have only the visual loss and the optic nerve atrophy, but you can have these other neurological features such as migraine, movement disorders. We described families presenting with myoclonus, for example. You have peripheral neuropathy, multiple sclerosis-like phenotype. You can have heart conduction defects, hearing loss, and in rare case, you can have also mitochondrial mutation associated with the combination of optic atrophy and also Lee syndrome. So the association between Leber's and MS-like, as known as Harding disease, is quite controversial in the literature, in the sense that it's not clear if this association is causal or just coincidental. Some studies try to address these issues, and the conclusion, for example, of this analysis in 2013 is that although the co-occurrence of MS and Leber's mutation is likely to be due to chance, the resulting disorder has a distinct phenotype which implicate a mechanistic interaction between the two diseases, in the sense that you have some atypical features for Leber's in these patients presenting with both LHON and MS, and a typical feature for MS. For example, absence of ocular pain and poor visual prognosis. Another important point is that the classical LH1 is the disease associated with the mitochondrial point mutation that I already mentioned, but recently have been described also Leber's in association with the recessive mutation in this nuclear gene, which is called DNAJ30. The peculiarity of these mutations is that they have been found in the majority of cases in people coming from East Europe, Russia, Romania, Ukraine, and Poland, and is possible to hypothesize a founder effect as demonstrated by the fact that the majority of patients are carrying the same mutation. An important message for these cases is that the clinical picture, the presentation of visual loss is completely identical to the classical Leber's, and there is also a good response to idibenone therapy, which is the therapy approved for this disease. There are other more rare genes which are affecting the complex one, for example, these two. And there are also a gene associated with the Leber's phenotype, which is involved in fatty acid biogenesis, which is called MC80. This is to underline that the Leber's phenotype can be associated also to rarer mutation affecting not only the mtDNA, but also nuclear genes. As I said before, the usual peak of the disease is around 20 years of age, but there are also very early cases, the so-called childhood onset cases before 10 years. And the clinical presentation for these young persons is can be completely identical to the classical adult manifestation of the disease, but also you can have more slowly progressing cases without the typical acute onset of labors. And as you can see from this graph, you can clearly recognize two peaks. One is related to people who don't smoke, and then you have this pink line, which is representing people smoking. So as you can see, people smoking are more likely to develop the disease later, which means that people with this genetic predisposition, the association with this smoking habit is triggering the disease even late in life. Moving to therapeutic option for this disease, the only approved therapy for labors, which has been approved in 2015, is idebenone. This is a molecule which is able to bypass the complex 1 defect, which is typical for labors, and is converted to idebenol by NQOA. This drug can be now prescribed in Italy for free under the rules of rare diseases with an IFA-web prescription in patients older than 14 years of age, and can be prescribed only for disease duration lower than 1 year. In other words, you cannot prescribe this drug if the disease duration is more than 1 year. The treatment should be initiated as soon as possible, and the dosage is 900 milligrams per day. The therapy can be continued until the stabilization is reached, and this is evaluated in 6 months interval period. So if the patient is not presenting further improvement after 2 consecutive 6-month interval evaluation, the drug is stopped. Another more recent therapeutic option for this disease, which is only for the 11778 mutation, is the gene therapy, which is based on the use of intravitreal injection using AAV2 vector, in which is collocated an ND4 gene construct with the mitochondrial target sequencing, which is target to mitochondrial and specifically to retinal ganglion cells. So by this approach, 3 clinical trials has been conducted in Europe, and all of them already closed in terms of recruitment and of follow-ups, even though some of the patients are still follow up in some center. So as you can see, many centers have been involved in these gene therapy trials, and the first 2 trials have been using unilateral injection. The second one, the REFLECT trial, is based on bilateral injection. So as you can see from this graph, the results coming from these gene therapy trials are encouraging in the sense that if you compare the visual acuity outcome for people treated with people untreated, you can see there is a quite significant difference in terms of visual recovery. And this improvement seems to be more pronounced for people which have been bilaterally injected. There is still some controversies about the first results of the clinical trials, because, for example, for the first 2 trials in which only 1 eye was injected, you have a bilateral improvement even though the injection was made only in 1 eye. And the plausible explanation for this bilateral improvement is that there is a crossing of the virus between the 2 eyes along the chiasm. The other common mitochondrial optic neuropathy is dominant optic atrophy. In this case, you don't have a maternal inheritance because mutation are affecting the OPA1 gene. So you have an autosomal dominant inheritance, and not only the female can transmit the genetic defect to their children, but also males can transmit the defect, as for all the Mendelian diseases. And the OPA1 gene mutation are responsible for 60–70% of dominant optic atrophy cases. So is the most common gene associated with these dominant optic atrophy forms. There is also in this case a variable penetrance, and the clinical presentation for this disease is completely different from Leber's, in the sense that for Leber's you have this very acute onset of visual loss, and the patient is rapidly going to be blind. In this case, the progression is very slow, and usually recognized when the patient is going to school, usually around 6 years of age. And there is no significant worsening in the large majority of cases during life. As for Leber's, also for this disease, we have this tissue specificity. In fact, retinal ganglion cells are the only target of the disease for the same reasons that I was explaining for Leber's. So as I said before, also for this disease, in the majority of cases, you have this isolated optic atrophy, and you have this childhood onset with very slow progression and incomplete penetrance. But in about 20% of OPA1 mutation carriers, you can have multi-systemic disease, and this is the so-called OPA1 plus phenotype, which include also sensory neural deafness, CPO, myopathy, peripheral neuropathy, and ataxia. And in these patients, you can recognize also the accumulation of mtDNA deletion. And as I said in the webinar last week, you can have in association with OPA1 mutation also some movement disorder like Parkinsonism. This is a classical concept for Mendelian diseases. So this is a family which I saw very recently, and you have these two brothers, and this is the father. And as you can see, for the youngest son, you have this clear temporal defect with a clear low vision. This is the brother, which is not complaining anything, and the vision is completely normal, and visual fields are completely normal. And you have this very subtle defect at the OCT level. And this is the father who was not complaining anything. The vision is completely normal. You can still recognize some temporal pallor, but the disease penetrance can be very variable, even in the same family, carrying the same mutation. So as for Leber's, there are some therapeutic options, even though there is no approved drug for this disease. But we have some experience with idibenone, also for OPA1 dominant optic atrophy. In fact, also for this disease, there is a clear complex 1 defect, which is the rationale for using idibenone for OPA1 as well. And even though there are no clinical trials randomized looking at the efficacy of idibenone therapy for OPA1 patients, we recognize some benefit from this therapy in comparison between patients treated and untreated, even though the use of this drug at the moment is still off-label and not covered by a specific legislation. More recently, there are some gene therapy options under study, which are still at the level of animal models and IP's evaluation, but more recently, there is some also option in preparation for patients using this gene therapy approach, which is aimed at increasing the levels of OPA1 protein. The problem with OPA1 in terms of gene therapy approach is that this protein is present in 8 isoforms, so it's very difficult in terms of using the isoform, the right isoform for gene therapy approach. So Leber's and OPA1 are the most common mitochondrial optic neuropathy, but there are a lot of patients with a clear inherited optic neuropathy, which are still without any genetic diagnosis. And besides Leber's and OPA1 that I'm already mentioned, there are other genes which can cause mitochondrial optic neuropathies, and the list of this gene is increasing over years, also due to the increase in the diagnostic possibility. So you can recognize for hereditary optic neuropathy both mitochondrial DNA mutation, but also optic neuropathy due to nuclear DNA mutation, both in autosomal recessive and autosomal dominant forms. So the diagnostic possibility, which were a lot increasing using this next generation sequencing approach, allows to evaluate a lot of new genes associated to inherited optic neuropathy. And for example, in Bologna, we have available this next generation sequencing panel, which include 36 genes associated with mitochondrial optic neuropathy. And you can recognize the most common optic neuropathy nuclear gene, which is OPA1, but you can see also other rare genes. The interesting point about these rare genes associated with mitochondrial optic neuropathies is that they are, most of them, they are affecting mitochondrial function, not only in terms of mtDNA maintenance, but also in terms of indirect impact on mitochondrial function. For example, there are genes involved in the fatty acids the biosynthesis. There are genes involved in the Krebs cycles. All of them are sharing the same phenotypic characteristic, which is the typical temporal pallor, which is characterizing all the mitochondrial optic neuropathies, even though the genetic pathway behind the clinical manifestation can be different. So the list of these genes are increasing year by year, and but the common theme is the mitochondrial dysfunction, which is direct or indirect. So in this list of genes, you can recognize also proteins implicated in mitochondrial dynamics. For example, mitofusin 2, which is a typical profusion factor as OPA1 is, but also you can recognize as causative genes for optic neuropathy, also a protein involved in fission of mitochondrial. For example, this MIF-F1. So all of these genes which are involved in the mitochondrial dynamic maintenance can cause optic neuropathy. And as I mentioned before, also genes like FG3L2 and SPG7, which are typical associated, for example, for FG3L2 to spinocerebellar ataxia, and for SPG7 to paraparesis, can be associated to optic atrophy without any other neurological features. And the reason for this is that both these proteins are involved in the OPA1 processing. So the common pathway is the OPA1 abnormal processing, which causes the optic nerve disease. And interestingly, also there are genes which are involved in the mtDNA maintenance. For example, this SSBP1, which is leading to a phenotype which can be characterized by isolated optic atrophy, but you can have also the association between optic atrophy, retinopathy, kidney disease. And in this case, you don't have, as for OPA1, for example, the accumulation of mtDNA multiple deletion, but you have a partial depletion of mtDNA, which is leading again to this typical phenotype of severe optic atrophy. And another gene that I was mentioned before, which is involved in the Krebs cycle, is ACO2. And the mutation in these genes were in the past associated to recessive forms of syndromic cases, which associated the optic atrophy and cerebellar atrophy in most of the cases reported. But more recently, we described also dominant ACO2 mutation in association with isolated optic atrophy. And you can see also in these cases the presence of the mtDNA depletion. And finally, this is an interesting point to highlight. There are diseases like, for example, Wolfram disease, which is not a primary mitochondrial optic neuropathy, but in this case, you have the association of optic atrophy, diabetes mellitus, and diabetes insipidus. And the problem is related in the connection between mitochondrial and endoplasmic reticulum interaction at the level of MUMS. And even though the dysfunction is not primary mitochondria, you have a secondary mitochondrial issues related to calcium mishandling. The difference between Wolfram syndrome and Leber's, for example, in terms of optic nerve involvement, you don't have the typical papillomacular bundle defect, but you can have usually a more generalized defect. But the optic atrophy, the optic nerve, is still a frequent target of the disease. There are other more rare genes like this RTM4IP1, which can cause either syndromic forms which associated epilepsy, ataxia, cerebellar ataxia, and peripheral neuropathy, but recessive mutation of this gene can be associated also to isolated and syndromic optic neuropathies. And with this, I would like to thank all the people working with me, and specifically also all the neuro-ophthalmologists in Italy with which I'm collaborating. And thank you for the attention.
Thank you, Chiara. Very nice presentation. I appreciated particularly the putting side by side the more clinical and physiopathological sides with the more genetic background. Very, very nice and very interesting. So today we have a question to start, and it's not coming from me, it's coming from René de Cou. I'm going to unmute him so that he may voice his question. So René, you are unmuted.
Yep.
With
Yep,
would you?
Yep.
Yes, we do.
Thank you, yeah, for the excellent overview. I was intrigued by the first case with the boy with Leber's, 16 years of age. You first treated him with the ND4 mutation, and you treated him first with idabenone, and later on you referred him for gene therapy. And my question is, he improved, but he was very young when he started with the therapy. So my question is, what makes you sure that, I mean, I'm very happy that he got better, but the question is, what did the trick? Is it the gene therapy, is the idabenone, or is it the natural course?
Okay, So for including him to the gene therapy trial, we had to stop Diabenon. So that was one of the exclusion criteria. So it was on Diabenon just for 1 month, actually. Mm-hmm. So I don't think Diabenon made any difference for that case. Regarding your question about the age, you are completely right. We know that young people are more prone to have good prognosis. Yeah. So we don't know if the good outcome in this case is related to the gene therapy or not. And for this he was involved in the bilateral injection trial. So we don't know if both eyes were injected or just one because of the randomized design. But you can recognize some difference between the two eyes, which is maybe related to the gene therapy. But you're right. We cannot say that gene therapy is the reason for this significant improvement. We cannot be sure.
Okay, and if I may follow up on the gene therapy, I don't know if you have experienced with more patients, but my question is also for the when they use the one eye injection, and as you explained, it could be a little bit of a crossover of virus to the other eye, that the other eye improved, but it's so difficult to imagine that the huge amounts of AAV2 you need to get into the mitochondrion and get the ND4 expressed, that a few particles will get into the other eye. Because when that's the case, I would say inject it just in the bloodstream and treat everything.
Yeah, this is one of the most controversial part of the gene therapy results. And you know that there are these findings from monkey models where they found the presence of the virus also in the other eye, but the amount of viral vector was lower than the first eye injected. So I agree with you, which is something I would expect a more significant difference between the two eyes if I'm thinking about the amount of virus in the two eyes. So it's difficult to explain only in this crossover. Maybe there is some explanation on the occipital plasticity, but usually you should expect also for this mechanism a longer response. So yeah, this is still controversial, I agree.
Thank you very much for the nice explanation.
Thank you.
I would just add to this interesting exchange that probably after the trial is finished and closed, the unblinding of the injection sites of that patient may be very interesting for you. In this case, you found some difference between eyes. It would be interesting to know if it did indeed bilateral or unilateral plus sham injection.
Yeah, yeah, absolutely.
Okay. Marco Macucci, please unmute yourself. I've allowed you to talk and put your question, please. Well, I don't know if Marco is able to unmute himself. So Marco asks, could you suggest 3 or 4 red flags for a rapid clinical suspicion in the non-academic neurological practice to select patients for genetic evaluation?
Okay. So yeah, for Leber's, I think I highlighted the main points, which is acute bilateral visual loss affecting the central vision, not recovery, mainly young males. This is very classical. For the other, I would say that the clear message should be that when you see an optic nerve affection involving the temporal sector of the optic nerve, even though you have just optic atrophy, you have to think about a mitochondrial optic neuropathies. Then you can have all the combination, but if you have this temporal sector preferential involvement, this is quite typical for mitochondrial diseases.
Mm-hmm. A bit on a follow-up of that question, I would like you to tell me if you know from the literature and or yourself, your own experience, how frequently Leber becomes misdiagnosed, at least not the most severe forms, as papillitis or benign intracranial hypertension. Do you have an idea how frequent that happens?
I don't have the exact percentages, but I would say if there is no clear family history, this is the common misdiagnosis. Actually, we don't see, I would say, never patient in the very, very acute cases, because they are always misdiagnosed as optic neuritis. They are treated with steroids, and since they are not recovering, only just this failure of the therapy, they are coming to us. So yeah, it's very, very common still.
Okay. Well, I think that we've gone through a good explanation of these entities. We have a very nice, refreshed idea about how to act in front when we face a patient, and what are the flags that we should watch and see to avoid misdiagnosing the patients, although I suspect that we will still be misdiagnosing some patients. And
yeah, for example, I would just to add for Leber's carriers of the mutation, as you mentioned, because they have this swelling of the fibers around the optic disc. If you don't know that there is this family history and they are carrying the mutation, they are misdiagnosed as idiopathic intracranial hypertension because of the optic disc appearance. So
yes.
Yeah.
So a red flag for Marco would be we should always ask the family history when we see a swollen papilla. So, and I confess I didn't used to do it by routine. So I'm sure that we will be able to improve our practice after this webinar. Thank you very much, Chiara.
Thank you.
Very nice and very kind from you.
Bye-bye.
Bye-bye.
To everybody.